He's been waiting on this.
So C2 is here. Bifid spinous process, so I'm using two fingers next to each other. It feels more comfortable. Tell me which one feels more comfortable, Jeremiah. This one here, or this one here?
The second one feels more comfortable to me.
So this one here. So two fingers next to each other, two thumbs to get right on that spinous process. I have a larger surface area. Larger surface area is going to feel more comfortable. Find R1. In the neck, it's kind of. I would never say yay. I would always say thumbs. Maybe in the thoracic spine I can get here and I can do this. In the neck, I would be afraid, especially with novice students, that someone might like kill it. So I'm gonna say no. For the purposes of our exam, if you use the PZ form in the neck, that would be a failure. So C2, you can start thoracic down with PZ form, but the neck, no. Maitland-wise, manual therapy-wise, examination should always occur with your thumbs because you get more input through your thumbs. You can examine and diagnose with your thumbs. When you treat, you can use the PZ form, but when you're examining, you need to use your thumbs. So C2, PA, R1, any pain here? No pain at R1, R2, any pain here? You say yes or no?
No.
No pain. So no pain, cleared. Same thing when we did the general motion extension. When we did that, overpressure, no pain, we clear the joint. So we can clear that segment when you have no pain. So C2, no pain. Go C3. R1, any pain?
No.
Yeah, it's fine. You could, whatever's comfortable. I understand. R2, any pain? And if you guys see me, like you can't feel what I'm doing, but you see how I'm rocking, I'm not, like some of you guys, like when you do it, you're like, and you just push really hard and you like go straight down. You see how I'm rocking into it. It feels comfortable to him. And so he's not going to tense up. If I just push, see, like, is that as comfortable?
No.
So you rock into it. And if you see I'm not using my hands, I'm using my body. I'm rocking into it. So I cleared C3. I went to C4. Any pain here? C4 is actually the way, because that's where the curvature starts.
Yeah, it feels weird there.
So what I'm going to do is I'm going to change the angle a little bit. Bring your head down. And I'm actually going to change my fingers and I'm going to angle them up. So instead of my fingers being this way, because that angulation changes, I'm going to get them straight up a little bit. And I'm just going to go, so I'm in the plane of the spinal process. So I'm going straight down versus here where I was just like this. I'm changing my angle and getting up. And I'm pushing straight down. My left thumb is hypermobile, so it looks funny, but my right thumb is the one you want to judge. See how my right thumb is straight down? My left thumb, you see how it looks?
C2, C3, same hand placement. C4, change it.
Yep, just change it to this middle segment.
Like C3, C4.
Anything there?
Okay.
Okay. I'm going to go to the next segment. R1, anything here? R2, anything here? He hesitated a little bit, so I may not believe what he said. I may keep that in the back of my mind. It felt fine, though. Like, he doesn't have any issues. So, and I'm just going to keep going, keep going, keep going, keep going, keep going, keep going. T6, T7, stop. If he had pain at C5, what I'm going to do at C5, if he said, ow, that hurt. When I'm at R1, he said, ow, that hurts. Am I going to push into R2? No. I'm going to stop. And then what I'm going to do is I'm going to move about a finger width away. And then I'm going to go on a transverse, but articular pillar for the zygopophyseal joint. And I'm doing thumb over thumb on the transverse, the laterals. So these are centrals, these are laterals, unilaterals. So
what are you checking?
the facet joint is going to be, if you put all your fingers together like this, your ring finger is going to be where the facet joints are. So I'm just, like his spinous process is here, ring finger's here. So his is about 2 finger widths apart. And I'm just going to get on that C5, C6 one, just push down R1, any pain, and R2, any pain. And if you say, ow, that hurt, then I know that's the segment that's in dystonia.
Sorry, can you do the side too, please?
So C2, C3, C4, C5, ow, that hurts. I'm gonna go on the lateral side here, do unilateral, any pain here. He has no pain, go down to R2, no pain. Then I'm gonna try the other side. R1, pain, ow, is that your pain? Yes, that's my pain. And then that's what was gonna happen to you. And then it'll be like, ow, that's my pain. We push on it and we're like, okay. If I keep pushing, like doing grade 1, grade 2, how's that feel? Does it feel better? It feels better. Let me keep moving it. Let me keep moving it, getting it to move better. If it feels worse, I'm just gonna switch on the other side and do the same thing. That's how you can go from your examination right into your treatment. So, but that's the centrals and the unilateral PAs. When you get in here, you can still do all that stuff, but once you get here, you still wanna move them here, like this. But then if you wanna treat, you can use a PC form. And that's just how I look at it. But in the thoracic spine, if you did it, it'd be okay. And here, I don't know how you can get your PC form on here and not really, and know exactly where you are, because the neck is so small.
You still use that kind of same finger width for thoracic to get to the transverse processes, or do you go
Thoracic's different. We've been in thoracic, we'll talk about this thing called the rule of threes, and then rule of threes is BS. But what you can do is find the spinous process, transverse process is usually about a half a segment up from the spinous process. The spinous process is here, the transverse process of that same segment, so if I'm pushing it here, I'll come up about half, like the other spinous process right there, so about half, and then that should be right there, and if I push there, I can feel the spinous process pop under my finger, but we'll get into that when we get into thoracic surgery. So PAs, practice that, because that's what you really need to know. Because you guys need to know how to treat. And so that'll help you with treatment. PA central, the way they say it, and I'll send something out, people say like, if I'm on C5 on C6 and I'm pressing on C5 right now, C5 helps to increase extension. So if I'm pressing C5 and C6 centrally PA, that's going to push C5 on C6 and it's going to cause extension. If I'm on C5 on the right side and I'm pushing a PA, that's going to create that rotation to the opposite side. So a left PA on C5, right PA on C5 is going to cause left rotation. If I do right unilateral on C5 and C6, it's going to cause right rotation. Makes sense? No?
It does. You just said it backwards.
I did.
You
I
said
thought
right
I
on
said
right.
You said right on right. That's why
Right
I gave
on
him
right.
that look.
Like a right
Right.
unilateral.
I pushed
PA.
on the right and then
But you
caused
said
it to
right
rotate
rotation.
to the left.
Yeah, you
You
said
said
it.
right.
I know what you meant. You just
Okay.
didn't say it.
Okay. You can show me later.
I got you.
So if I push on, it's going to cause contralateral rotation, if you guys understand that. So, but the research shows that that's BS. The research shows that if I want to increase extension, I got to get them up into extension and do the mode. If I want to increase rotation, I need to rotate them and do the mode. If I want to do rotation in this direction, I need to turn them a little bit and do the mode. So some of the most recent studies where they can do biomechanical analysis show that the people's, like our thoughts on mobilization really isn't true. So I say this to say, like, do whatever makes your patient feel better. Like, don't follow the rules all the time.
I was gonna say, would you suggest once you get that person, let's say you're trying to do rotation to the right, turn them to the right, then you're doing a central mode, or you do turn to the right and then do a left unilateral?
Do whatever works.
Whatever works. Okay.
Honestly, I would get them in a pre-manip position and do some nice little glides, like some other stuff. These are just the basics, like. But once you learn some of the other modes and stuff, like you won't do like the PAs. You may do them because the PAs always work. There's a study that showed that like PAs, like if you do the PA glide assessment, like the person doing the diagnosing was 100% accurate. So I mean, that's pretty phenomenal. If you could feel with your fingers, you could be very accurate on these patients. If you can't, then you might want to do outpatient. So, I mean, not outpatient, sorry, inpatient, where you don't have to do this.
Those central PAs, I'm not sure if I heard you right. Are we pressing on the transverse process to start off, or on the bifid spinous process?
I mean, I know we don't have a little bit enough time, but if you want to practice, then cool. If not, I will make the jaw lecture short. I'll try to make it like as short as need be for the test, which is not a lot. So I mean, the lecture is done, and I did it for a dental conference, so it's really in depth. But I'll chop it up.